Good evening, everyone, and thank you for joining us to learn more about what you should expect post-kidney transplant. I am Nicole Haar, Director of Community Engagement at the PKD Foundation. I will be with you throughout the webinar, so if you have any questions, you can send me a message via your chat box. We are recording this webinar and will archive the recording on our website within the next few days. Please note, the PKD Foundation does not offer medical advice, and the information shared this evening is not intended to be a substitute for consultations with your health professionals. Care and treatment decisions related to your health must be made in consultation with your health professional team. We received questions ahead of the webinar, and these have been shared with our presenter. We will do our best to address any questions you may have throughout the presentation at the end of the webinar. All attendees will remain muted throughout the presentation to ensure good audio for everyone. Please type your questions into the question box in your control panel. We will address questions related to the webinar topic at the end of the presentation. Our speaker for this webinar is Mandy Riester. Mandy has worked with transplant patients for 7 years. For the last 4 years, she's been the inpatient kidney nurse coordinator at University of Kansas Health System, teaching new kidney and pancreas transplant patients how to care for themselves immediately following their transplant. Mandy has a passion for the transplant community and for PKD patients. Mandy, feel free to share your screen.
Thanks, Nicole. All right. Well, hello everyone. I'm so glad to be here tonight to share information about what to expect after transplant. I love working with the PKD Foundation and I am passionate about kidney transplant. So it's a privilege for me to speak with you tonight. I have a lot of the same information that Nicole has already gone over, but I wanted to tell you before we get started that I work for the University of Kansas Health System, and therefore all my material is from the University of Kansas, from their procedures, protocols, and approved educational materials. Centers for Medicare and Medicaid, as well as the United Network for Organ Sharing, do regulate transplant centers, so there will be similarities between centers or from center to center. We'd like to keep things as general as possible. My hope is that all of you feel better prepared and educated regarding post-transplant. This webinar does not constitute medical advice. Also, all of my experience is with post-transplant patients. I do know a bit about pre-transplant, but I won't be able to answer a lot of questions about listing or evaluation before you've been transplanted. We'll be covering quite a few topics tonight. I wanted to share a summarized outline of what we'll cover with you. The topics include the members of the transplant team. We'll go over the actual surgical procedure and talk about immediate recovery and then hospitalization. I'll discuss the immunosuppression medications with you guys, our methods used to help patients with those, and also side effects that you may expect. I will do a summarized run-through of the transplant teaching that I do with our patients. We'll also discuss potential complications and the long-term outlook and expectations. Lastly, we'll have some time to go over questions. First of all, I wanted to say that your transplant team is very important and that'll be a good indicator for your success. You'll be working very closely with the team, specifically a physician and nurse coordinator post-transplant. You'll be entrusting your health to them. There are often many physicians and nurse coordinators on each team. If you feel you may work better with another team member, please speak up. You definitely want to feel that you are heard by your team, but also trust that the team has your best interest at heart and will advise you accordingly. If you feel the team is not a good fit and you have the resources, you can always do evaluation and be listed at a different center. Listen to your gut on this and you have a lot of options. All right, so getting started. This is a list of the most common transplant team members that you may see right after your surgery. It's not an exhaustive list, but these are the most common people. First listed is the transplant surgeon. They do the actual surgery. For kidney or kidney pancreas transplant, there's typically only one surgeon in the operating room. They may have a resident or a fellow, which are doctors that are learning how to be the top, they haven't graduated from residency, but they're learning how to do the surgery and helping the surgeon in the operating room. Also, there is an anesthesiologist. They are present for the surgery. They'll keep you breathing but sedated, and they're also responsible for giving you medications while you're sedated. They help with pain control after surgery as well, so you may see them round after you go back to the floor. At our center, the transplant surgery nurse practitioners round on patients and do a great deal of the day-to-day care management. So you'll see them as well if that's available at your center. The transplant nephrologist is the specially trained kidney doctor, and they follow patients long-term after transplant. We also have transplant-trained pharmacists for post-transplant patients. Pharmacists go through each medication ordered for patients in the hospital and outpatient, and they also do teaching with patients to ensure that patients know about side effects and what each medication is for. The transplant dietitians will meet with you to discuss nutritional needs and how to manage your diet post-transplant. A social worker will meet with you while you are hospitalized to discuss, among other things, Medicare enrollment and discuss how you are coping, among other things. A case manager is someone who helps with discharge planning, like copay cards for medications, home health setup, or getting equipment for you at discharge, like a roller walker. There are transplant coordinators. Their primary role inpatient is teaching you how to take care of yourself after discharge. They also help coordinate care after discharge and try to keep all the members of the team aware of what the plan of care is for you. Physical therapists and occupational therapists are specially trained to help with mobility after transplant or after any procedure, and they help with a lot of hospitalized patients. I've indicated by a star or asterisk team members that are not mandated to be part of the multidisciplinary team per CMS or Centers for Medicare and Medicaid. For example, one of the caveats we have in our team is we don't have a dedicated transplant case manager. Those duties fall under the transplant coordinator. So that's something that we don't necessarily have to have, but we've worked out a plan for our patients to have the best care. Moving on to the surgery. During the surgery, typically a small incision is made in the pelvic area. If it is your first transplant, the kidney is typically placed on the right side. I've included some pictures to show you kind of how the incision is made, and they try to make it pretty small. For kidney alone transplants, the actual surgery lasts 2 to 3 hours. Pancreas transplants take longer. You may wake up from surgery with a drain in place or something called a wound vac. I've included a couple pictures on this slide of the most commonly used drains and wound vacs at our center. The team will explain these drains to you if you do come out of the surgery with them in place, and they'll show you how to care for them, especially if you're going to discharge with them still in place. Most often, I would say about 75% of the time, these drains are removed before discharge. Depending on the surgeon, you'll either have staples or surgical glue closing your incision. During the surgery, the surgeons cut through your abdominal muscles in order to make the smallest possible incision, but also access your vessels and your bladder. Most surgical pain and discomfort arises from that incision and from the hindrance of using your abdominal muscles. You use those abdominal muscles for almost every motion your body does, so you can feel pretty sore after surgery doing anything. Another part of the transplant surgery is the implanted ureteral stent. The surgeon places this straw-like structure, there's a picture on the right here, in the donor's ureter, which is then sewn into the recipient's bladder. So you can kind of see in this middle picture that there is a stent in that ureter, and then it coils into the recipient's bladder. The picture on the left shows the basic anatomy of where the new kidney is placed. It's important to note that your native kidneys are likely to not be removed during the transplant, especially with PKD patients. Surgery to remove PKD patients is pretty complex, and it's a very long procedure typically. So the surgeons will leave that to another time if you do need your kidneys removed at a later date. And again, I've talked about how these pictures kind of show where the stent is and what it looks like alone. As I previously said, this stent is implanted during the surgery. It is not a permanent implant, and it's usually removed anywhere from 6 to 12 weeks after transplant by a urologist. The procedure is done outpatient, and you're likely to be awake for it. The urologist does use numbing gel and then removes the stent. Typically, the procedure lasts less than 5 minutes. It's common to experience burning or stinging when you urinate after the procedure. This will be very similar to when they remove the Foley catheter in the hospital. The symptoms will decrease as the day goes on, so by the time you get to bed, you shouldn't be having any issues with urination. All right, moving on to immediately after surgery. When you wake up from surgery, you'll be in the post-anesthesia care unit, which we also call the PACU. You'll be groggy as you wake up from anesthesia, and you will have a catheter in place collecting your urine. They put this in while you're under in the operating room. It is absolutely necessary for this to be placed for accurate urine measurement after transplant. Urine measurement is one of the most important indicators of how well your transplant is doing. So the team wants really precise input and output numbers so they can see how well you're doing. You may stay in the PACU for anywhere from 2 to 6 hours after surgery. Then, if you're stable, you'll be moved to your hospital room. At our center, your nurse, when you go to your hospital room, your nurse only has 2 patients, so they can dedicate a lot of time to your care. You'll have to get hourly vitals, and they'll check your urine output every hour and then adjust your IV fluids accordingly. You'll likely still have some of the medications in your system from surgery, and this will make you sleepy. You'll receive a great deal of IV fluids in the OR and then post-operatively. So if your kidney is slow to wake up after transplant, which can happen, you may gain a lot of fluid weight in the first few days after transplant. The team will be watching this and making sure that they're taking care of that. The day of surgery is called post-operative day 0, just so you have a frame of reference, because I'm going to go through a couple of the post-op days here. The first day after surgery, or post-operative day 1, the most important thing for you guys to know is that you will be expected to get out of bed. You may only get to the chair for a few hours and it may wipe you out, but it is essential that you move early and often. For each day you stay in bed in the hospital, it takes 3 more days for your muscles to recover. You will be sore. At our center, patients usually come up to the floor with a pain button or PCA. I've included a picture of a pain button that's attached to the IV pain medication. This PCA usually comes up with you from the PACU to the floor and stays usually post-op day 1. And then you'll be transitioned to oral pain medication if your bowels are waking up. Oral pain medication is much better because it does last longer, so it gives you relief for a much longer period. Your room will be what we call a revolving door of doctors, nurses, therapists, dietary assistants. It'll be pretty active, and a lot of this is because you won't be in the hospital very long, so people need to see you while you're there. You may get some cat naps in, but you will not get a significant amount of sleep during the day or at night, really, while in the hospital. At night, it would be possible to have about 6 hours of sleep with no interruptions if you're stable. But the nurses and nurses' aides will need to be getting vital signs and all that stuff. The inpatient coordinator will also try to meet with you on post-op day 1 and give you information about transplant education. At our center, that's my job, and I usually go in and introduce myself and give the patient a transplant binder full of important information and let them know what we'll review together. I try to discern who the main support person is and ask when they would be available to do teaching. Post-operative day 2. Patients are expected to continue to make strides with mobility. This helps with healing and with bowel function. The anesthesia you were given in the operating room puts your bowels to sleep, and the team will be listening for them to wake up. It's not safe to allow patients to have solid food or oral pain medications if their bowels are not making noise, because then there's a risk of nausea and vomiting. Vomiting with a new incision is no fun, so we really want to go slow and steady here. If your bowels aren't waking up fast enough, the team may get a bit more aggressive with the bowel regimen. The inpatient coordinator is likely to try and teach you and your support person on this day, especially if you're doing really well and expected to discharge on post-op day 3 or 4. Also, it's possible the team may remove your Foley catheter on postoperative day 2, and you'll have to get up to urinate, so you'll be moving quite a lot. On postoperative day 3, amazingly, if you're doing well, you could discharge. Before you get too excited, it usually takes most of the day to actually discharge you, so set your expectation at later afternoon or early evening, because a lot has to happen. If you haven't gotten your transplant teaching by the coordinator, this will happen before discharge. Your medications will be reviewed and a pillbox teaching will be done with a transplant pharmacist. You and your support person need to be there for this teaching. I'll touch on transplant medications on the next few slides. This is a picture, it's an example of the medication list we give patients at discharge. It's customized to each patient and it's called MedAction Plan or My Med List. There's an app you can download to your phone where you'll get any changes to your list delivered to you. I believe it also has an alarm to remind you to take your medications. I've included a link that Nicole can post on the PKD website to let you explore this further later down the road. Here are 2 larger copies of the medication list. The left list includes Prograf, which is the twice daily immunosuppressant medication, and the right has Envarsus, which is only taken once a day and becoming more commonly used. Prograf and Envarsus are at the top of the list because they are the most important after transplant. Oftentimes you'll be on more medications than are listed here, including many medications that you were on prior to transplant. Sometimes you'll still need to be on blood pressure medications. Rarely will you need to continue with like phosphorus binders or Readol vitamins. You will discharge on a lot of pills, up to 15 twice a day, I would say. Eventually, some of those pills will be stopped and you'll have less of a pill burden. While you were in the operating room, you will receive IV immunosuppression, which we call induction. The typical medications that we use for induction are called thymoglobulin, Simulect, and a steroid called methylprednisolone. You won't receive all 3. They're just examples of what is usually given to prevent rejection in the operating room at the time of that the kidney is hooked up to your body. The most important thing I need you to hear tonight is that you will need to take your immunosuppressant medications for the rest of your life. As long as you want the kidney to work, you'll need to take the medications. Your body and immune system will not get used to the kidney where you could stop them. This is your most important job as a transplant patient, to take your medications every day. The immunosuppressant medications are also referred to as anti-rejection medications. I've listed some of the most common brand name medications, and in parentheses is the generic name. Prograf, Myfortic, and prednisone are the most common combination at our center, although we are starting to use Envarsus more, which is a once-a-day form of Prograf. Some other medications include Cellcept, Rapamune, and Zortris. You will be expected to be proactive about your refills. Please, please, please do not call your transplant center on a Friday at 3 p.m. and say, I ran out a couple days ago. You're going to run into problems if that happens. And also, please do not page the after hours and tell them you ran out a week ago. We want you to be on top of your supply of medications. You need to tell the team if you're asking for refills and the pharmacy is not being helpful, they can have ways to get to the pharmacy that may be a little bit more effective. You need to tell the team if you start any new medications so that they can let you know if that's okay for your kidney and that it doesn't interact with your other meds. We strongly discourage you from ever taking a medication classification of the NSAIDs, which stands for non-steroidal anti-inflammatory drug. These include ibuprofen, Motrin, Advil, Aleve, or naproxen. We only recommend Tylenol for over-the-counter pain control. And at our center, the pharmacist will give you a list of over-the-counter meds for allergies and sleep and things like that that are okay and not okay. The one exception to the no NSAIDs rule would be a baby aspirin if a cardiologist or another physician has told you you need to take that for heart health. A transplant pharmacist will review side effects with you during your hospital stay. I'd say the most common side effects of medications are diarrhea, infection, and then low magnesium and phosphorus levels. You need to let your team know if your life is significantly affected by a side effect. Cost of medications, this has come up as a question. It can be a big undertaking and a deterrent for some people. I'm not a financial or insurance expert, but I do know that if you have Medicare A and B at the time of transplant, Medicare B will cover 80% of the cost of immunosuppression medications. If you have a secondary insurance provider, it may also help cover your copay. I would say the copay for generic Myfortic and Prograf, which you're gonna probably be on both of those, would be about $100 each per month. Our transplant team has financial advisors that meet with patients during evaluation to discuss cost of medications, and your insurance would also be a good resource and may have insight into copays. Our pharmacy, I know, has really good insight into patient assistance programs and things like that, so you may try your pharmacy as well. You need to let your transplant team know as soon as possible if you can no longer pay for your medications. They can make a few backup plans for you, but you need to tell them before you run out. Myfortic or Cellcept is the second drug on your list, typically, and is also an immunosuppressant that works in a different way from Myfortic or Envarsus. It is contraindicated in pregnancy. In fact, we don't recommend that pregnant women even touch the tablets. If you, for example, have a family member or friend who's pregnant and helping you maybe fill your pill box, you need to be the one that touches this medication, or they need to be wearing gloves, or you need to get someone else, because it's that big of a deal that we don't want them to even touch it while pregnant. If you are on Myfortic or Cellcept and wish to become pregnant, you need to advise your transplant team well in advance, preferably more than 6 months. The team will work a plan to transition you to a different medication that is safer in pregnancy. Lastly, don't ever crush or chew your medications. You always need to take them as advised. The med list that I showed you earlier has advice and little places for comments that'll say things like that. Don't crush this pill, it's long acting, things like that. Having support after transplant is vital, and you'll need to have family or friends, the more the merrier, available to you around the clock. For example, if you got an organ offer and needed to come to the hospital at 2 in the morning, you need to have somebody that's going to help you with that and be able to drive you or be with you. We also want family or friends to be able to help you with your journey. The pre-transplant team will likely set the expectation that you identify a support person, if not require you to bring a support person to your pre-transplant appointments. You need to call the transplant team if anything happens to your primary support person. There are several reasons we recommend you have support. First of all, after transplant, you won't be able to drive. You'll likely be in pain, and you'll have limited mobility. So you'll need help doing day-to-day things. Secondly, the transplant teaching can feel overwhelming. It's a lot of information, and having another set of ears to hear can be helpful and take some pressure off of both of you. If you're on pain medications, it may be hard to stay awake or remember the teaching. And lastly, if your support person can be with you at the hospital every day, they can be there when the doctor's around and hear what the doctors say about the plan for you, and they can also advocate for you. It is not recommended that a living donor be a support person if the surgery occurs at the same time for both the living donor and the recipient. So if you're on the list and you have a loved one or a spouse that wants to be your living donor, we don't recommend that the donor, be your support. You both actually need a support person. The living donor recovery is pretty difficult, and actually the living donor needs their own support person. I'm not a living donor coordinator, but I do know that they have restrictions. Living donors do have restrictions after surgery, like they can't drive for 2 weeks and they can't lift. So you'd need somebody to drive you both to appointments and all that kind of stuff. So now we're transitioning to what I would do for my post-transplant education with patients. These are a summary of the information I share with them. So as far as follow-up goes, it can be pretty intense after you discharge from the hospital. You'll be expected to come to clinic at least weekly to see the physician and to get labs at least twice a week. If complications arise, you could be asked to come to clinic or get labs more frequently. As you progress and do better and better, the team will decrease the frequency of your appointments and your labs. They'll let you know that you can now go every other week, for example, between visits. Our center requests that patients from out of town stay within 60 minutes of KU for the first 2 weeks after you're discharged. This is for 2 reasons. We don't want you to have to do long car trips with your new incision. That can be really, really uncomfortable. And if we're making you come up twice a week, that can really wear you down. Secondly, if something were to happen, we would want you to come to our emergency room or our clinic to be seen because our surgeons will want to see you, and we know the work we did for the transplant, and it'll be better for all parties involved. As I discussed before, the surgeons cut through the abdominal muscles, which puts patients at risk for hernia. The surgeons will not fix a hernia until many months after the surgery, and that's because of the risk for infection. In order to avoid developing a hernia, there are restrictions after transplant. These include no lifting over 10 pounds, which is the equivalent of a gallon of milk, for 6 weeks after surgery, no driving for 4 weeks. Yes, 4 weeks. And really the most activity we want you to do is walking. They don't recommend sexual activity for 4 weeks after transplant, and they strongly encourage you to not go back to work for 6 weeks until at earliest 6 weeks after transplant. After discharge, you will be asked to track your vital signs, including blood pressure, temperature, urine output, and weight. This will be for about the first 2 weeks after discharge, and it helps the transplant team track how well you and your transplant are doing while at home. Also, it's possible you'll need to measure drain output or blood sugars if those are applicable to you. As I mentioned a few times before, after transplant, you will be at higher risk for infection. For the first month after transplant, you'll be at even higher risk because of the medications you got in the operating room. So we recommend no crowded places or sick visitors for that first month. You'll be discouraged from ever cleaning kitty litter boxes or bird cages because those animals have pick up diseases that they expel that can make you very ill, especially in the lungs. You can have pets, that is okay, after transplant, but you need to be careful about licking and scratching and make sure that you're taking care of any kind of wounds where you've interacted with a pet. You need to become a bit of a germaphobe after transplant and make sure you're washing your hands a lot or using hand sanitizer. We recommend you stay up to date with vaccines like the flu shot, pneumonia shot, and tetanus shot. But we won't want you to get any live vaccines again, and those would be like the shingles vaccine, although there is a new one that isn't live. Our center has not recommended that yet. And also the yellow fever is a live vaccine, and the flu mist that goes up the nose is a live vaccine. Again, wash your hands. Can't say it enough. There will be some limitations on diet after transplant. First of all, you'll be asked to avoid grapefruit and pomegranate completely, as both of these interact with your medications and will make them less effective. Due to your risk for infection, you'll need to ensure your food is cooked adequately, and you need to avoid raw or rare food or meat. Buffets are not your friend, as it's hard to know how long food has been sitting out and developing bacteria. It's common after transplant, especially if you're doing really well and your creatinine's dropped quickly, for the team to encourage you to increase phosphorus and magnesium in your diet, as your electrolytes may be low. High phosphorus foods include meat, dairy, dark soda, seeds, and beans. And high magnesium foods include fresh fruit and vegetables, almonds, and whole grains. If you've been on dialysis, this will be a complete 180 from what you were told you could eat while on dialysis. You'll want to continue with a healthy diet after transplant so you do not gain weight. Weight gain is associated with the development of diabetes post-transplant and also could mean that your drug levels would be affected. The FDA website is a great place to check in for food recalls. Post-transplant patients are the ones at highest risk for foodborne illness, so please be careful. As far as complications go, they do occur, unfortunately. About 15 to 17% of patients will have a post-surgical complication. On the flip side, that means about 80% of patients experience no complications. The risk does decrease after about 6 months post-transplant. I'll talk more in depth about rejection in the next slide. The first month of transplant is the riskiest month for infection, but there will always be a risk. We'll talk a little bit more about infection as well. Delayed graft function may occur where the kidney may not wake up immediately after surgery. This means you would need at least one dialysis treatment in the first week after transplant. And sometimes, unfortunately, patients do discharge on dialysis for up to a few weeks until the kidney wakes up and is fully functional. As you will be started on a lot of new medications, you could react or have an adverse reaction to those medications, so that's a possibility. Also, there's a higher risk of acquiring diabetes after transplant, and it actually happens often enough that it has its own name, which is called new onset diabetes after transplant, or NODAT. As with any surgery, there is a risk of post-surgical complications where you may have difficulty breathing, blood clots, wound infection, urine leaks, and fluid collections. Now, I wouldn't say that surgery-related risks happen a lot, but I wanted you to know what all of the risks are. So usually we don't see a ton of, as I said, the 15 to 17% is the not a ton of complications, but they can occur. So as far as rejection goes, creatinine is the lab value that the transplant team will be looking at after surgery. This is different from how kidney function was measured before transplant, which is usually done by looking at GFR, which stands for glomerular filtration rate, or how quickly your kidneys can filter. Creatinine is a normal product that comes from the breakdown of muscle and is filtered by your kidneys. If your kidneys aren't working or filtering much, more creatinine will be circulating in your bloodstream. Someone who has 2 fully functioning kidneys will be expected to have a creatinine of anywhere between 0.5 to 1.2 milligrams per deciliter. For example, a petite woman with little muscle mass would be expected to have a creatinine pretty close to 0.5. On the other hand, if you have a big bodybuilder, their creatinine would be expected to be closer to 1.2 or even a little bit higher, and that would be normal for them. After transplant, each patient has what we call a baseline range. The way we get a baseline range is by looking at the lowest creatinine you had after transplant. For example, one may have a baseline range of 1.2 to 1.4 milligrams per deciliter. If this person gets labs 1 month and the creatinine is now 1.8, there will be red flags going up for the transplant team, and they will ask that person to complete further testing. Further testing can include a donor-specific antibody, an AlloSure, or an ultrasound. If the team can't find a reason for the bump in creatinine, they may ask you to get a transplant kidney biopsy. Some centers do protocol biopsies every couple or every 6 months. However, our center only does them when there is concern. Though the risk decreases, as far as rejection goes, there are 2 types, which are antibody and cellular, that can occur after kidney transplant. The team will want to move quickly with treatment if they do find rejection. Treating rejection can take anywhere from 5 to 10 days in the hospital, depending on the type and severity of rejection that is found. Rejection treatments have come a long, long way, and patients can live healthy lives with working kidney grafts for many years after treatment. It's important that you move quickly and recognize how serious it is to get quick treatment for rejection. If you refuse to get treatment or even the biopsy, the likelihood of losing your transplant drastically increases. Your risk of rejection is highest at the time of your surgery, and then decreases over time. So 20 years after surgery, the risk will be a lot lower, but there is still a risk. The trick, as it were, after transplant will always be riding the fine line between rejection and infection. If you're on too much immunosuppression, your risk of developing an infection increases. If you are not on enough immunosuppression, your risk of rejection goes up. This may sound exhausting and overwhelming, but keep in mind you have a whole transplant team behind you that is invested in you and your transplant. Getting your labs on time and taking your meds on time and keeping in communication with the team will help you stay healthy. As I mentioned earlier, due to the immunosuppressant medications, transplant recipients are at a higher risk for infection. I've listed and will review some of the most common infections that arise in this population. First off is CMV or cytomegalovirus. This virus is related to the herpes virus and is very common. By the age of 40, over 50% of adults have been exposed to CMV. By the age of 80, over 90% of people have been exposed to it. For people with active immune systems, they usually feel like they have the flu and get over it quickly. Patients who've been transplanted will have more severe symptoms like diarrhea, prolonged malaise, and fatigue. The team can test for CMV in your blood. For the first 3 to 6 months after transplant, you're likely to be on a prophylactic or preventative medication called Valsite or valganciclovir. This will help your body protect itself from CMV, from your body reactivating it, or from you getting it from your donor. Next is PJP, which is an acronym for pneumocystic gyrovechi. I don't know if I said that right, but it's close enough, which is a lung infection that is common among immunocompromised populations. To prevent patients from developing this infection, they are placed on Bactrim, which is an antibiotic, or Dapsone if you're allergic to Bactrim. Lastly is VKV, which was named after the doctor who founded it, so I'm not sure what it stands for, but it's also known as polyomavirus. Again, not a problem for those with active immune systems, but it can be dangerous to those with transplants. It does show up in blood work, and the transplant team usually monitors for it. It occurs when patients are over immunosuppressed. After transplant, patients are at higher risk of developing cancer due to the immunosuppression medications. They're really getting you. The immunosuppression medications are the best way we have to treat our post-transplant patients, but they do come with a lot. A few recent studies have looked at the risk of cancer in kidney transplant recipients and compared them to people of the same age and gender, and found the risk is higher with transplant patients. About 4 to 5% of transplant patients will develop cancer. The most commonly reported cancer after transplant is non-melanoma skin cancer. So transplant teams strongly suggest patients protect themselves from sun damage and follow with a dermatologist at least once a year. You'll need to ensure that you're getting your cancer screenings on time. These include colonoscopy, prostate exam, mammogram, and pap smear. Although we never want a patient to choose transplant out of fear, it bears mentioning that there are risks associated with staying on dialysis as well. The decision needs to be weighed carefully between you and your medical team. What does having a kidney transplant look like in the long term? Hopefully a fuller, more enjoyable life not connected to a dialysis machine. The national statistics show that a deceased donor transplant lasts around 12 to 15 years. Living donor transplanted kidneys would be expected to last even longer. There are exceptions to this. At our center, we have patients who've had their transplants for 40 plus years and are still doing great. In 2014, a new kidney allocation system went into effect with the purpose of better matching the expected life of a kidney with the expected life of a recipient, with the goal that each recipient would only need one kidney transplant in their lifetime. If you take care of yourself post-transplant, you can expect your transplant to last quite a while. I will say that it is not the standard of practice for a kidney to be retransplanted. When the first recipient passes away, the kidney is not given to another recipient. There's a lot of details in that where the DNA and the blood types and antibodies can be built, so it's a little difficult to keep passing that kidney on. Another question that had been submitted prior to the webinar was about whether kidney patients could travel, and if so, where to. While we certainly wouldn't recommend travel within the first 3 months after transplant, we don't limit it after that. We do have a rule of thumb, which is that patients need to take a supply that's twice what they think they need when they travel. So if you have a week-long vacation planned, you need to make sure you have at least 2 weeks worth of medications with you. We don't limit where you travel to. I will say that if you are going somewhere that's known to have to cause intestinal issues or have parasites, that you'll want to make sure you have bottled water or boiled water and keeping safe so that you don't get those parasites. And then moving on to questions. I have one question that was submitted that I couldn't really fit anywhere else, and it pertains to if there are age limits for getting listed for a transplant. The answer is not necessarily. The team looks at the whole picture of the patient, including functional status, which means how well they get through day-to-day life. And they also look at comorbidities, like if the patient has significant heart issues or cancer. The older a patient gets, or a person gets, the weaker their immune system gets. So often older patients do experience more infections post-transplant, but there's no absolute age cutoff at any transplant center. And now we're open for questions you guys have submitted.
Mandy, thank you so much. That was really great info, and I know everyone that's on tonight really appreciates it. So we are ready to take some additional questions. I have a few more that have been submitted, so I will start with those. I believe you've answered pretty much everything that was submitted before the webinar, but we might go back and address a few of those as well.
Okay.
If you have questions, just type them into your Q&A box, and we'll get to as many as we can. So I think you talked about how many medications you have to take after transplant. Could you just give us a brief little overview of that again?
Sure. So the first medication, the most important one, the Prograf or Envarsus, that medication is determined, the amount that you take is determined by a blood level that they check because it is actually filtered through your kidneys. So if you have too much, that can be hard on your kidneys, and if you don't have enough in your blood, that could put you at risk for infection or for rejection. So depending on your blood levels, you could be taking anywhere between 1 Prograf pill twice a day or 10 Prograf pills twice a day. And then the next would be Myfortic, which is typically anywhere from 2 to 4 pills. So it is quite the pill burden in the beginning. I would say actually 15 to 20 pills, maybe in the mornings right after transplant. And then within the first 10 days, you'll have one medication that does fall off. Typically, it's a swish and swallow to prevent fungal infection. And then if you're taking off the prednisone, that'll fall off as well. A year after transplant, you should be on a significantly lower amount of medications than you were right at transplant, just because of that risk for rejection and that risk for infection. So it's hard to nail down an exact number of how many meds each patient will be on, just because everyone's body is different and how they metabolize things is different.
Okay, thank you.
Yeah, no problem.
Can you clarify how many weeks you indicated that you would not be able to drive after your transplant?
Sure. So for recipients, it would be 4 weeks. And for a living donor kidney, somebody that's donated their kidney, it would be at least 2 weeks after their surgery.
Okay, perfect. What about having young children around after a transplant? Is that okay?
It's tricky because they do tend to be sick more often. You know, if it's children that live with you, obviously, you know, that can't be avoided. And I've had patients kind of make a game out of using hand sanitizer when their kids' friends come over and things like that. But otherwise, if you can avoid, you know, in the first month after transplant, you know, if it's avoidable, then try to avoid it. But if not, just make sure everybody's washing their hands really well, and maybe, you know, if they're sick, keeping their distance.
Okay. You mentioned, we did talk a little bit about age for a transplant recipient. What about an age limit for living donors? Can you address that?
I think it's the same rule. Again, I'm not in living donor, but I don't think you'll probably find a hard and fast rule for age. It depends a lot on what the overall picture is. I think I've seen recently that there was a donor, I think around the age of 80 maybe, that was able to donate. So it just depends. You can have, really healthy 80-year-olds and really sick 40-year-olds. So it's really a case by case. They take it case by case and review it with the team. And we really try to be careful about living donors because they are putting themselves at risk. They're signing up, from going from a healthy state to going to a little bit, impaired with one kidney. So you'll find a lot of centers that are more conservative with their donors just because we want to make sure that we take care of them. That can be really hard on them.
Okay, that makes sense. Thank you for that.
Mm-hmm.
Are thyroid problems common after a kidney transplant?
That's a good question. I know they're common with dialysis patients, I think particularly with parathyroid. And I know patients that experience parathyroid problems before transplant, it doesn't get fixed immediately at the time of surgery. You can have some lingering effects from that, and that will show up with the electrolyte imbalances. I haven't heard of an uptick in problems after transplant if you haven't previously ever had a problem. And I haven't heard much about a lot of thyroid cancers after transplant. So I don't think so. If you had an issue on dialysis, then yeah, that could continue for a little bit after transplant or even, long-term after transplant.
Okay, here's a question that I think a lot of people can probably appreciate. If you have problems swallowing large pills, is that going to be a problem?
Yes. So there are workarounds. This has come up before in our center. There are a lot of liquid versions for different medications, or, we can sometimes break apart certain medications. But it would be something that would be a little bit more work between the patient and the team to work around, but there are quite a bit of pills. So that could just be a little bit more difficult, but it's not necessarily a complete no, that you could
Okay.
still be listed, you could still get a transplant.
Okay, and can you talk a little bit more, because we have several questions about recovery for the donor, how long the donor's recovery would be. We've got several questions about, and I know you addressed a support system, not relying on each other for support. Can you share a support person? Like, would one person be able to take care of both the recipient and the donor? But just a little bit more information on the donor part after surgery would be nice.
This isn't my forte, but I know typically for donors, they stay in the hospital 2 to 3 days. It can be rough out, I'll be honest with you, for donors because they're going from a healthy body to down to one kidney, and they can have quite a bit of discomfort. So we definitely want to keep them comfortable and don't want to put added burden on them for having to take care of somebody else while they're pretty uncomfortable. I would not underestimate how long it'll take you to recover. I think it's a lot more than people may think it is.
Mm-hmm.
But again, yeah, there's a restriction for no driving for 2 weeks after you've donated, no lifting over 10 pounds for a month. So, you need to help with groceries and all that kind of stuff, getting to your appointments, because they're at risk for a hernia as well. You can share a support person. I'd want to make sure that support person doesn't have any other responsibilities. And I think probably caring for the recipient would be a little bit more arduous just because of the vital signs, and they do have more frequent appointments than the donors do. But maybe just think about it. It's a lot to ask from somebody to take care of 2 people. But there are a lot of amazing people out there, so they could maybe do it all. And then I don't know exactly what the follow-up looks like for donors. I think maybe 1 week after they're discharged, and then every couple of months or so, I would say. that we'll be looking at their labs and making sure they've bounced back pretty well after donation.
Okay, thank you. That was very helpful. Can you talk any about bone density after your transplant?
Oh, this will depend on whether you've been kept on prednisone long term. So there are centers that are adamant that everyone needs to be on prednisone as a third immunosuppressant medication after your Prograf and your Myfortic. And higher doses of prednisone are associated with lower bone density. The research and data out now says, most centers would decrease you down to about 5 milligrams of prednisone a day, which is roughly about the amount that your body releases anyway, because your hormone system does release a steroid. So it shouldn't affect your bone density as much. But if you do, if you are getting follow-up and you have concerns about that, you can always talk to your team about, the fact that you think you need to get off the prednisone, or that you need help, get, other medications that you may need to take to help with bone density. But yeah, that can be, especially with higher steroid doses, that can be a concern, but we don't see it a whole lot just because the new wave of thinking is to use less steroid.
Okay. Here's a good one. Are there restrictions on gardening after a transplant?
Oh, yes. So there are bugs that you can pick up, not literal bugs, but bacteria and fungus and things like that from gardening. The team's not going to be super enthused about you gardening after transplant. Again, that's one of those things you can have a conversation with them about, but that is a very real risk that you would pick something up. And, you might be able to work out with your team where if you're wearing gloves and washing your hands really well, excuse me. You may not need that.
Thank you. Sorry about that.
You're fine. All right, I'm all right.
Okay, I'm sorry. What about any symptoms if your body is starting to reject a transplanted kidney? Can you address that at all?
Sure, yeah. So typically rejection always shows up in your lab first. Sorry, hold on one second.
Okay, if you need to jump and get a glass of water, that'd be fine.
All right. All right. I'm back. Okay. So typically it always shows up in your labs first. And usually patients don't even know that something's going on. They feel normal. And what I like to say to my patients is that the creatinine is the canary in the coal mine. So that's usually what happens first. But yeah, there are physical signs, symptoms that you can have. They would be fever, nausea, vomiting. Your kidney would feel like a hot rock under your skin. You'd have little to no urine output, and you'd be swollen, a lot like when you need a dialysis treatment. If you'd had dialysis before the transplant, you would recognize those symptoms. And typically, I haven't seen this very often in probably my 4 years on the floor. I've seen 2 patients that actually have severe enough symptoms that, they come to the hospital with them. And that's just kind of a balancing act. I like to tell patients that because sometimes I feel like, well, first of all, that's the biggest concern, and rightfully so. That's a big deal. But, if you feel a little twinge or you feel a little nauseous, please don't assume that you're rejecting. Talk to your team, get your labs, but I would say 95% of the time they're going to see it first because they're reviewing your lab results.
Okay. Let's see here. What about any new developments in immunosuppressive medications that maybe have less side effects or a reduced risk of cancer post-transplant? Do you have any information about that?
I know that they're always working on those kind of things. I will say I know we're using Envarsus more, which is the once-a-day medication that does help with tremors and people that have neurological side effects. with their Prograph. There are things that are being developed. I know that if you are having a significant, if you are currently dealing with cancer after transplant, the team will probably transition you off of the Myfortic and switch you to some of those other things that I mentioned, like maybe Rapamune or Zortress, that help a little bit more, help your immune system fight that kind of stuff a little bit more. I'm not sure, I'm not up to date on if they're developing medications that will be, you know, a lower risk of cancer. There is an interesting article out there that says that it's almost an equivalent risk of cancer on the immunosuppressant medication compared to staying on dialysis, which was kind of interesting, about 2.5 times the risk of the normal population. So I think that they're always developing that. I know, you know, I don't know how close we are, but 3D printing would be an interesting technology. I know that there's been a study with living donor recipients getting bone marrow transplants from the recipients get it from the living donor, which is quite an extensive procedure. And the recipients only then need like a once-a-month shot. But that is a lot to ask from both the recipient and the donor. That's pretty extensive. But there are people that are out there still working on, you know, medications that are, you know, less harmful with less side effects.
Okay. Thank you for that. I'm going to ask one more because I know we are approaching the top of the hour. If you are working in the healthcare field or a hospital, is it safe to go back after work and maybe just, or after the transplant? And I'll add to that, you know, we talked about children a little bit. Are there other, I guess, work-related issues that might come up that you would want to talk to your doctor about before you go back to work? If that makes sense.
I would definitely recommend, you know, there are some, if you're in the medical field, there are some pretty nasty resistant bugs out there. So, you know, if it's possible to not, you know, maybe have a patient, if you're a nurse, have a patient that has a really resistant bug or, you know, has an easily, you know, like the flu, you really don't need to be in a room with a patient that has influenza. So, you know, I always think that's good. And if it's not avoidable, just make sure you're protecting yourself with masks and gloves and things like that. But I can't emphasize enough how much of a risk there is with infection, and not to make, I don't want people to live with fear, but, you know, just that fine line between, you know, you are at risk, but, you know, you can be careful and you can have a long, healthy life with not, you know, a lot of hospitalizations or infections and things like that. So it's just a balancing act, really.
Okay, makes sense. Well, that is all the time we have for questions tonight. Mandy, I just want to thank you for answering all these questions and for the information that you provided. And as Mandy mentioned, there may be some differences from center to center, so please make a list of all your specific questions and take them with you when you visit your transplant center. The PKD Foundation appreciates the opportunity to speak with you and provide the best possible education. After the webinar, you will receive a very brief survey. We appreciate your feedback and we will use your responses as we develop additional resources and programs in the future. When you do complete the survey, please include additional topics that you would like for us to address in future webinars. If you do have additional questions, especially if we didn't get to your question tonight, please feel free to email us at pkdconnect@pkdcure.org, and a member of our team will get back to you as soon as possible. On behalf of everyone at the PKD Foundation, we wish you a lovely evening. Thanks for attending, and good night, everyone.
Thanks.
Thank you, Mandy.